Welcome to The Explainer. Today, we're doing a rapid, high-level clinical briefing on minimal change disease. We're going to move fast, starting from the foundational presentation and those tricky diagnostic paradoxes, all the way to the cutting-edge biologics that are completely reshaping our treatment protocols today. So, let's just dive right in.
Now, you already know the glomerulus has this intricate, beautifully complex filtration barrier. But when we talk about minimal change disease, or MCD, we aren't just looking at some generic kidney issue. We are zeroing in on a highly specific podocytopathy. The entire clinical picture we're going to unpack today hinges on the structural and functional failure of the podocyte, literally those exact cells wrapping around the capillary loops.
Let's establish our clinical baseline. MCD is defined by massive proteinuria and nephrotic syndrome where, and this is the wild part, there are absolutely no abnormalities visible on standard light microscopy. None. The damage is entirely ultrastructural, showing up only as foot process effacement on electron microscopy. And epidemiologically, you've got to remember the stark contrast here. MCD drives a massive 70 to 90% of nephrotic syndrome cases in kids. It's the most common cause for them. But in adults, much rarer, making up just 10 to 15% of cases.
Here's our roadmap for The Explainer. We'll start with pathophysiology, hit clinical presentation and diagnosis, and then cover first-line corticosteroid therapy. After that, we'll get into managing relapsing disease, explore those exciting emerging biologics, and wrap up with complications and special populations. All right, Section 1, Pathophysiology, the podocyte puzzle. What's actually driving this invisible damage?
So MCD is fundamentally a disease of immune dysregulation. We're looking at T-cell dysfunction that triggers this abnormal release of Th2 cytokines, specifically IL-13 and IL-4, which essentially launch a direct assault on the glomerular filtration barrier. Plus, there's a critical overexpression of CD80, also known as B7-1, right on the podocytes themselves. And this overexpression disrupts the actin cytoskeleton, literally causing the podocyte's feet to collapse. We're also dealing with a long hypothesized circulating permeability factor, which, still hasn't been fully characterized, alongside a generalized reduction in regulatory T-cell, or TREG function. That basically just lets this podocyte injury run completely unchecked.
Moving on to Section 2. Clinical presentation and diagnosis. How does all this molecular chaos actually show up in a patient?
When an MCD patient walks into your clinic, they're going to present with the absolute classic hallmark features of nephrotic syndrome. We are talking massive proteinuria, greater than 3.5 grams a day in adults. And because they're losing all that protein, they develop profound hypoalbuminemia, dropping right below 3 grams per deciliter. Naturally, this loss of oncotic pressure leads straight to generalized edema. You'll usually spot this first as periorbital swelling or even ascites. Meanwhile, the liver is desperately trying to compensate for the protein loss by ramping up synthesis, which concurrently triggers hyperlipidemia and, subsequently, lipiduria.
But here is where MCD truly earns its name, and it's that diagnostic paradox I mentioned earlier. If you look at the biopsy under light microscopy, the glomeruli look entirely normal. Seriously, no cellular proliferation, no scarring, and immunofluorescence shows zero immune deposits. It looks perfectly healthy. But the second you switch over to electron microscopy, the reality hits you. Diffuse, catastrophic podocyte foot process effacement. The architecture is just completely flattened. This stark contrast between completely normal light microscopy and dramatic electron microscopy findings, that's the absolute diagnostic hallmark of this disease.
Now, because the presentation in kids is overwhelmingly likely to be MCD, standard of care dictates that a renal biopsy is actually deferred in classic childhood cases. You basically just go straight to empiric treatment. But in adults, the protocol is strictly different. A biopsy is absolutely mandatory for adult patients presenting with nephrotic syndrome. We have to definitively rule out heavier hitting pathologies like focal segmental glomerulosclerosis, membranous nephropathy, or even secondary causes like NSAID toxicity or lymphoma.
Section 3. First-line treatment with corticosteroid therapy. So once we've got the diagnosis, how do we actually induce remission?
While corticosteroids are still the absolute cornerstone of induction therapy, but you've really got to tailor your approach based on the patient's age. For the pediatric protocol, we hit it with high-dose prednisolone at 60 milligrams per square meter per day. Kids usually have this fantastic rapid response. We're talking about 80 to 90% achieving complete remission in just 4 to 8 weeks. But contrast that with the adult protocol. Adults are started on prednisolone at 1 milligram per kilogram per day, and here's the crucial part. Adults respond much more slowly. You really can't rush this. Getting full remission in an adult might take 12 to 16 weeks of continuous therapy. In fact, you don't even declare adult MCD steroid resistant until they've failed the full 16 weeks of induction.
Which brings us to Section 4, Managing Relapsing and Steroid-Dependent Disease. What do we do when first-line therapy just isn't enough, or the disease keeps bouncing back? When patients are relapsing frequently, or they become dependent on steroids just to stay in remission, we have to pivot to steroid-sparing agents. Our traditional second-line heavyweights include cyclophosphamide at 2 to 3 milligrams per kilogram a day. It's highly effective at knocking down relapse rates, especially in kids. But you've got to watch those cumulative doses like a hawk due to the severe risk of gonatotoxicity. Second up, we have calcineurin inhibitors, CNIs, like tacrolimus and cyclosporine. Super effective, but ironically, they carry a significant risk of nephrotoxicity with prolonged use, so you're religiously monitoring trough levels. Finally, there's mycophenolate mofetil, or MMF, dosed at 1 to 1.5 grams a day in adults. MMF is becoming increasingly favored as a less toxic alternative for patients who just can't tolerate the side effects of cyclophosphamide or CNIs. All right, Section 5, Novel Emerging Therapies and Biologics. While those traditional agents absolutely work, they carry some heavy baggage. Let's step into the future.
And this brings up a vital question for modern clinical practice. What exactly is the next frontier for steroid-resistant and frequently relapsing disease? I mean, if we know this is a disease of immune dysregulation, how can we target the immune system with more precision than just relying on systemic steroids?
Well, the evidence in nephrology has evolved incredibly fast over the last decade. Back in 2015, we got pilot data for abatacept, which directly targets that podocyte CD80 overexpression we talked about. Then 2019 brought a massive shift with the Mentor trial. That trial proved that rituximab, a B-cell depleting antibody, was actually superior to cyclosporine for maintaining long-term remission in adults. By 2022, studies were showing that even a single dose of rituximab could achieve sustained remission, which just drastically reduces the steroid burden on these patients. Also in 2022, ofatumumab started being successfully deployed for patients who developed rituximab allergies. And right now, in 2023 and 2024, we're closely watching Phase 2 trials for next-generation agents like inebilizumab and obinutuzumab. So the whole paradigm is shifting heavily toward targeted B-cell depletion.
Section 6. Anticipating complications in special populations. Because as exciting as these new treatments are, we're treating the whole patient, not just a biopsy.
The crucial takeaway here is anticipating what's going to go wrong based on the underlying physiology of nephrotic syndrome. Take elderly patients, for example. Standard steroid doses carry massive toxicity risks for them. Think severe hyperglycemia, psychosis, and osteoporosis. You absolutely have to initiate bone protection therapies right from the start. Then there's acute kidney injury, or AKI. It's surprisingly common, hitting up to 25% of adult MCD patients. And this isn't usually from the disease itself. It's mostly driven by severe intravascular hypovolemia from the low albumin, plus compounded tubular lipid toxicity. Also, because these patients are just dumping massive amounts of protein into their urine, they're losing vital protective proteins. They lose immunoglobulin G, deeply impairing their humoral immunity, and spiking their risk for things like spontaneous bacterial peritonitis. And critically, they lose antithrombin 3 in the urine. That loss sets off a potent, hypercoagulable state, significantly bumping up the risk for DVTs and pulmonary embolisms. You always have to evaluate if they need prophylactic anticoagulation.
So we've covered the microscopic damage, the massive clinical implications, and those rapidly shifting treatment protocols. But I want to leave you with this final thought. With these highly targeted biologic therapies proving so remarkably effective in recent trials, are we finally nearing an era of genotype-specific, truly individualized therapy in nephrology? As we map out the specific molecular failures in each patient's podocytes, that old one-size-fits-all steroid approach might soon be a thing of the past. Definitely keep an eye on those clinical trials because the way we manage minimal change disease is evolving.